And welcome back to my YouTube channel. And today I'm very happy that I've invited on John, who's a practicing psychotherapist, and we're going to be talking about the pathologization of normal human psychological distress and neurodiversity. So that's our topic today. So welcome back, John.
Hello, nice to be here.
Yeah. Right, well, it's good to have you back. So so this is something we've discussed in the past, actually, the idea that sort of a lot of sort of what is quite normal human distress around, especially anxiety and depression, is becoming sort of increased. I think, it's becoming increasingly pathologized, or, people almost encouraged to kind of think that they may have depression or, some kind of anxiety disorder. And also, I think neurodiversity as well, especially in relation to attention deficit, ADHD, attention deficit hyperactivity. I mean, that seems to, the amount of people being diagnosed with ADHD seems to have gone through the roof in the last decade or so. So perhaps I could have your thoughts on some of these issues.
Yeah, I mean, just as a quick note, I mean, somebody told me the other day, I haven't researched this, but they're waiting for an assessment, and the waiting list is for ADHD is 18 months.
Right, yeah. So
that kind of gives you an indication.
So people are literally queuing up to get an ADHD diagnosis.
Yes, or alternative, as well as that, perhaps professionals in mental health are queuing up to diagnose them with that. It's a bit of both, I think.
Right. Is that because, you get a good fee for doing a consultation to give someone an ADHD diagnosis?
Well, I don't think it's that. I think it's that brings us into the whole other area. I mean, I think that part of this trend is basically it's the increasing diagnostic approach to human behavior, which has been going on for some years, and that takes us into the realms of psychiatry and the social control aspect of psychiatry. But I think it's a kind of consequence of, in the last 20 years, probably, or 25 years, there's been so much work done on the brain. That it's kind of fed into this. Perhaps I see it perhaps as an attempt to rationalize and impose a scientific view on human behavior and psychology.
But isn't that legitimate though? Because I mean, humans are biological organisms at the end of the day, aren't they? So, so really, like, I mean, what sort of creates and affects our behavior and our emotional states, that must be, in theory, that it should be subject to scientific analysis, and there must be like biological, I mean, it's a combination, I think, of biological and social explanations that affect our behavior.
It's just from my perspective, which is broadly humanistic, I feel that, the attempt to kind of define, and as Oscar Wilde, I think, said, to define is to limit. And in some ways, to always explain human behavior in terms of pathologies, illnesses, can be, well, I think it can be limiting. But for some people, of course, a diagnosis can actually be helpful. Some people, to know that there is a set of symptoms and signs that correlate to what they experience and find troubling on a daily basis, sometimes that can be really reassuring. I think the downside of that is that for some people, a diagnosis can become self-perpetuating. So this is my EUPD, for example, that makes me like this. This is the explanation and rationalization for everything. Whereas part of it is just being human. And then you've got the question.
Sorry, what's EUPD? Sorry.
Emotionally unstable personality disorder.
Oh, okay. Is that sort of a...
That's a very popular one in the last 5 to 10 years. Yeah, I mean, anxiety, depression, PTSD, and EUPD, along with ADHD, seem to be, in my experience, the prevalent diagnosis.
So is EUPD, is that like a new way of describing borderline personality disorder?
It's exactly that. It's exactly that.
Why have they changed the name of it? What was wrong with borderline personality disorder?
Well, that's a good question. You see, that's part of the scientific, it sounds better, I suppose. Okay. I think it's probably a better description of those sets of symptoms and so forth. But the thing that I want to kind of, my point really is that this diagnostic approach, from a medical perspective, the diagnosis is made and then treatment is offered.
Right, okay.
Which usually, well, pretty much most of the time, predominantly involves some form of medication. So, you've got, for ADHD, you've got a group of kind of stimulants like Ritalin and drugs of that family. There isn't really a medication for, as far as I know, for EUPD, although many people with EUPD are on antidepressants. I mean, of course, there are people in the field, working in the field as a whole of the mental health field, that are working to promote and recommend and encourage lifestyle changes, behavioral changes. For example, learning to manage your moods and feelings by healthy, non-medical, non-pharmaceutical means, which is, but I think that's kind of like probably the lesser extent. The greater extent, in my experience, is the medical pharmaceutical approach to these conditions, which I see as being basically there are differences in intensity and degree, but they're basically part of being human.
But maybe do you think the main reason why the intervention tends to be sort of medication based is because it's just less labor intensive, isn't it? I mean, because actually it doesn't, it's a quick fix, I guess.
Absolutely, Nigel. I mean, to give somebody a course of therapy, psychotherapy, or even counselling is so much more costly than to prescribe them sertraline or...
I mean, my view is it shouldn't be an either or. I think if anyone's taking any kind of antidepressant, they should also be in therapy, because I think if someone needs an antidepressant, then that also means that they should be having some kind of talk therapy, to help as well. So you should actually be you should either be using psychotherapy alone, or you should be using psychotherapy augmented with, an appropriate medication. But in my mind, you should never, if someone needs to be on an antidepressant, to me, that means they should be in therapy as well, actually. Like, I mean, not forced to be in therapy, obviously, but, therapy should be available to them, as an option. And I think anyone who can't afford to pay for it, themselves, should actually be offered that on the NHS, not just like for 6 weeks, but as a long-term thing. And obviously that would cost a lot of money, but I mean, let's face it, most people have to pay huge amounts in tax and national insurance. So I mean, so actually I think people who need that, they should have that on the NHS. So
again, if I interject, regarding figures. I mean, locally in the area in which you and I live, the waiting list for IAP, that's improving access to psychological therapies, basically is 9 months. So again, you know, so somebody presents to their doctor with suicidal ideation and mood swings, low mood and so on, and anxiety. Then the first port of call is always, and it can be effective for some people, get them out of a hole. But what is worrying is that it can become a long-term dependency, and like any dependency on drugs, it involves when it's the medication is stopped or reduced, it involves withdrawal symptoms. The other aspect to it is, I agree with you about the therapy being contemporary with the medication, but some therapists would argue that this isn't an argument against working with that particular client, but some therapists would argue that, and in fact they do, that a client who's on antidepressant medication is in less emotionally present in the therapy context. But that's not to say that they shouldn't have therapy. I agree they should.
No, I'd be inclined to disagree with that view, because actually I think, well, firstly, antidepressants, I think, well, maybe they vary in terms of their impact on different people, but I think for the vast majority of people, SSRI type antidepressants, that's the most commonly used these days, selective serotonin reuptake inhibitors, they don't really have like a huge effect on, for the vast majority of people, I don't think they make them less emotionally available. I think if someone's got really bad depression or anxiety, if anything, if they're in a really sort of angst-ridden state, it's all, they're, especially say with severe anxiety, they could literally be in fight or flight mode the whole time, or so, which makes it very difficult to attend to, to be emotionally available. I think, like when you're in a really deep hole like that, you just get a kind of tunnel vision where you can't really sort of, you're just in survival mode, basically. It's like your body and brain feels like it's under some sort of severe threat. I mean, the threat might not be real, but that's kind of how you feel inside your body and your mind. So it's quite difficult, I think, in that kind of state for therapy to actually be effective. Because of,
I would agree with that. I think, there is also another view that as a short-term measure, I think that's great. But in practice, a lot of people who go onto antidepressants are not regularly reviewed. GP. So it becomes, and that's simply because of pressure of work. So I'd be 100% in agreement with you that to get out of a really bad hole, antidepressant therapy it can be a good option. However, when it then spirals over a period of time into long-term dependency, and there seems to be a syndrome whereby some of these medications can actually encourage or compound the very symptoms that they seek to treat and alleviate.
Oh, right. Okay. Yeah.
I don't have any handy research to back that up. So
anyway, let's return to this. Yeah, because actually this anxiety and depression thing is interesting. So, I think we both agree that anxiety and depression are just completely normal human emotions. So it's kind of, it then becomes a case of when does anxiety become an anxiety disorder, and when does feeling depressed become an actual disorder? And I think that the sort of boundary between normal levels of anxiety and an anxiety disorder, and normal levels of feeling down, depressed, and having major depressive disorder, that the boundary is a little bit fuzzy, isn't it?
It certainly is, yeah.
And that's where the problem, and maybe the boundary is kind of shifted in the last decade, whereby some people who before would have just been seen as having just normal everyday anxiety that people have, or maybe they have anxiety as a response of an event that's happened in their life, like the loss of a loved one or losing their job. Whereas before that would have been just seen as like a normal response to a bad situation. Now that might be, I don't know, yeah, well, maybe that might be kind of classed as an anxiety disorder, or they might receive an anxiety disorder diagnosis or major depressive disorder diagnosis and then put on pills.
Yeah, I mean, I think in that case, what you're describing is called reactive depression.
Yeah.
Where it's a response to a set of stimuli, whether it be something that's happened in the person's life, as opposed to clinical depression, which is long-term and not particularly necessarily related to any chain of causation.
Yeah. So really, like, I mean, actually, a GP, so primary care physicians, are they allowed to give anxiety disorder or depression diagnosis, or does that have to be given by a psychiatrist?
No, it doesn't have to be given by a psychiatrist. It's a GP can and will prescribe antidepressants without, you see, the way it's done, like everything else in our contemporary world, is the equivalent of algorithms or whatever they're called.
Right.
You go to the doctor and you're asked to complete or the professional, and you're asked to complete I think it's a call 10, which is basically how severe is your anxiety, 7 or 2 or whatever, and then there's kind of, it's done numerically on that way, and this is necessarily so because there isn't the time for a GP or in a busy practice to investigate further and say refer someone to a psychiatrist. It simply isn't viable or feasible, really. Sadly the case. Because if somebody presents with suicidal ideation, extreme anxiety and depression, they're looking for some kind of help. Doctor, the medical model, the medical approach to all of these things is, there is identify a group of symptoms, whether that be physical or psychological, and then treat it. And that tends to be traditionally, identifying pathology and treating that with medication.
Right, okay. I mean, I'm more relaxed about doctors prescribing an antidepressant for a limited course of time, even if someone has got, I don't know, but I'm sort of I'm fairly relaxed about that, actually, even if it is like a reactive depression or reactive anxiety. I'm more relaxed about that than I am about them actually making a sort of diagnosis of an anxiety disorder or major depressive disorder, because to me, because the diagnosis can sort of take on a life of its own and it has power. I think, then, so if they're actually making diagnosis, to me, that is wrong, because that should only really, in my view, that should only be done by a psychiatrist or a clinical psychologist, and even not just based on one appointment either, maybe after several appointments, because I think there needs to be gatekeepers in a sense, because in my view, someone should only receive an anxiety disorder diagnosis if those anxiety symptoms have persisted for at least 6 months, and also if they're sufficiently severe that it's having a significant impact on their daily life, so it's making their daily life very difficult for them. So those would be like the criteria I'd be looking for, both for a diagnosis of clinical depression or
That is exactly
yeah,
you know,
because
the way that the medical model works.
Oh, okay. So to me, I think that's kind of valid, you know, a way of distinguishing between when anxiety is just normal anxiety that everyone has, or whether it's normal anxiety in response to a bad situation versus when it's anxiety that's outside of that normal kind of range, where it's actually having a huge impact on someone. To me, then it kind of makes sense to kind of class it as a kind of disorder, because something is kind of dysregulated. The person isn't really functioning like as well as they'd want to be, or as well as they should be.
Yeah, it's a tricky one.
Yeah.
Because you know, what can happen with some people is that the identification of the diagnosis in itself becomes affects that person's self-concept, the way they see themselves. So that I, for example, come to view my anxiety or my low mood or my irrational fears as being, oh, that's because I'm EUPD or PTSD. Or, I suppose the approach I'm coming from is basically that all of these things, even extreme anxiety, are potentially, you know, part of the human condition.
Well, I agree. I think even extreme severe anxiety is a perfectly normal emotion, but I think, but if it, you know, if it carries on like for days and days and weeks and months and months, that is definitely a problem then, like, because no human being can function like normally if I mean, if they're in that state over a prolonged period of time. So I think it's perfectly valid to then consider that, like,
yes, I mean,
to be a
100%.
diagnosable problem.
Sorry?
I think it's legit to consider that to be a medical, you know, a diagnosable health problem.
Sure. Well, you know, in specific instances, you know, I think, yes, many people benefit from antidepressant therapy, and it actually improves the quality of their lives, and therefore, in my view, that's absolutely justified. What worries me more, though, is a kind of trend in society towards diagnosis and I just find it worrying sometimes.
Well, it's definitely,
as you yourself mentioned, you know, the abundance of diagnoses of these kind of conditions has grown immensely.
Well, I think so, and I think part of that, I mean, so according to this American psychiatrist Alan Francis, he actually helped create the DSM-4, the Diagnostic Statistic Manual 4, and then but he went into retirement, but then he came out of retirement to kind of speak out against the DSM-5. So he was arguing that the DSM-5 massively increased the sort of the boundaries. In other words, it reduced the sort of the level of the criteria. You know, it kind of reduced the entrance price for being diagnosed with some of these different disorders. He said it massively increased the number of people being diagnosed with certain disorders, especially ADHD, actually, and also, you know, major depressive disorder and various anxiety disorders. So that, I think, that's the thing, the kind of the boundary is shifted between normal and what's classed as abnormal has kind of shifted, so that more of what would have been seen as normal before is now being seen as abnormal. So I think there is a problem with that.
You know, I prefer to view it rather than being in this kind of black and white. You know, you're EPU. I mean, and it's significant that in the DSM, which, not that I read it, but I'm aware of some of it.
I thought you had a copy, you know. I thought you said every evening. That's your nighttime
Yeah,
reading.
like reading, yeah.
Yeah, up on the
But,
latest diagnostic category. Yeah,
find in those diagnoses,
yeah,
if you look at the diagnoses for many conditions,
yeah,
they're
yeah.
very similar.
Oh, right, okay, yeah, yeah.
So, you know, it becomes, then raises the question of, are these diagnoses, you know, as I said before, an attempt to define and limit what's going on to a narrow framework. The other thing is, I mean, my view is that basically anybody can display or exhibit or demonstrate symptoms and signs of some of these conditions, but it's more about a more kind of nuanced than that. My approach would favor a more nuanced approach that kind of sees these things as constellations of symptoms that may occur in one individual. That yes, some of those symptoms do conform to a model of or a diagnosis of ADHD or PTSD. But my question is, you know, that is surely not the whole story. And it's that other element that I'm interested in, really.
Yeah, because I suppose, you're right. Because most of these psychiatric diagnoses, they just describe a sort of almost like a syndrome in a way. They're a kind of cluster of symptoms, and you get similar clusters of symptoms in some other psychiatric diagnoses as well. So they're almost kind of descriptive kind of categories more than anything else.
Yes.
So, and then I think every individual who has some kind of psychological distress is going to be different, aren't they, in terms of the sort of symptoms they have and the severity of those symptoms. So each individual is going to be different, really. So then I think maybe with the whole diagnosis, you know, categorizing people into different disorder diagnosis, I suppose the danger is you could end up treat the condition and not the person. So you got someone.
Absolutely. Yeah. That in a nutshell is my kind of viewpoint. You know, I mean, the other thing is, which we haven't touched on, is the issue of side effects.
Right, okay.
So, I mean, if we think about, for example, schizophrenia, and obviously the drugs are getting better. You know, from their emergence in the 1950s, they're getting more refined. However, and there is research that backs this up, the long-term effects of antipsychotics they seriously impact, for example, obesity. It seems to lower the life expectancy. A lot of people on long-term antipsychotic drugs die quite early, whether that be a result of the obesity and the general lack of a healthy lifestyle, but because of the degree of sedation.
Right.
Then again, with the antidepressants, they can affect your sex life, your libido.
I mean, not having much of a sex drive, I mean, that in itself can be a real downer, can't it?
Well,
I mean,
tell me about it.
Nothing's gonna make someone. I mean, that's for a lot of people, that's one of the biggest joys in life. So if that gets knocked out, that's got to be a downer, right? So I mean, people can underestimate. To me, that's a serious side effect, actually. Like having
serious,
even if it doesn't. I mean, obviously, in severe cases, it can cause impotency in men, like antidepressants. They're well documented, but even for people, it doesn't cause impotency, but it still, for the most part, seems to reduce people's libido significantly.
Another thing, some antidepressants can again promote weight gain, extreme hunger, some drug, metazapine, particularly, weight gain. Now, if your sex life is reduced, your libido is reduced, and you're putting on loads of weight because that's enough to make you more depressed.
Well,
it then becomes a bit of a vicious. That's the element of self-perpetuating. But the main thing that I think about self-perpetuating element is the way it affects the person, the individual's self-concept and view of themselves. And in that way, it can be limiting and perpetuate the disorder, in inverted commas.
There certainly are a lot of people on antidepressants, because actually I checked, I did a bit of fact checking, which, as you know, I love to do, John. So love to get to the numbers. So I found out that according to the Center of Disease Control, CDC in the US, like 25% of women over the age of 40 are on antidepressants at any given time. I mean, that's just an incredible number. One in 4 women over the age of 40 years old in the US are on antidepressants. I mean, that to me doesn't seem right somehow. I mean, to me, that's over-prescribing. That's got to be. I mean,
and it kind of begs the question, or raises the thought that perhaps significantly, you mentioned being over 40, could these symptoms and conditions be partly a result of the menopause, for example?
Doesn't the menopause? Oh, that's true actually, because menopause usually kicks in around 50, doesn't it? But if they're looking at
some women, it starts in their mid-30s, but on average about 45.
If they're looking at if they're looking at the cohort of women over 40, that's mostly going to be, that's including women that are over 50 as well. So that'll be so some of that could be related to the menopause, I guess.
I'm conscious that perhaps we're taking a sexist view there.
Because I think the overall prescription rate for antidepressants, I think it's in the population in general in the US is 12%, I think. So obviously it's so more women are on them than men, by the sounds of it. So what's causing that is a moot point. I mean, who knows? Like maybe men are less like. We could speculate. There could be all sorts of reasons. So, but anyway,
maybe men don't talk about it so much.
Oh, it could be that, or So, but anyway, like, actually, antidepressants are used to treat anxiety, not only depression. So, a lot of those women on antidepressants could be taking them due to an anxiety disorder diagnosis. And it is well known that women, whether they suffer from anxiety more than men, or whether they're just more likely to go to the doctor for presenting with those symptoms, is debatable. I'm not sure, but to me anyway, it feels like there's over prescribing going on. If you've got 25%, even 12% of the overall population seems an awful lot to me, actually. Like, and but actually, that's let's talk about this kind of concept of a diagnosis almost becoming like an identity, because I think I've noticed that a lot. That's going on a lot with autism spectrum disorder. That seems to be quite common. I was of the mind at one point that maybe autism spectrum disorder was being sort of overdiagnosed, but I'm changing my mind on that a little bit. Actually, I'm thinking more now that it's actually a lot of people that would have been diagnosed with autism spectrum disorder they wouldn't have been diagnosed with it in the past. It's just maybe there's more awareness of it now. So
can I just add one word about the before we get onto the autism?
All right.
The other thing that needs to be considered is what's going on in that individual's life. What social conditions that they live. Are they on very low incomes? Do they have limited access to some of the things that perhaps the majority of people in society can access. What I'm really saying is that the approach I would favor is one looking at the whole human being.
Well, yeah.
Their physiology, their psychology, but also their context in life, their relationships, are they in employment? Have they suffered trauma at an early stage in life? Because particularly with PTSD and EUPD, very often are long-term results of some form of trauma.
Yeah, well, I agree. You do need to look at the whole context of the person's life, because a lot of people, their actual daily circumstances might just be horrible, actually. And it would almost be strange if they weren't depressed or anxious, like living in those circumstances.
Exactly. Now,
so actually,
the GP can't do anything to improve their, can't give them money or a job or a partner. But, kind of, there needs to be, some consideration of these factors when you've got someone presenting to you, and you may well think, it may occur to you that actually, if I was in that person's shoes, I'd be really depressed and anxious.
No, that's a good point, actually. I mean, that's why I think a therapist can help with that, because a therapist can help someone talk about their situation and why that's making them so miserable. And a therapist can be a good listener and can sort of express empathy or whatever. And I think, by doing that, therapists might actually enable the person to kind of put together a plan of action. I mean, because actually when you speak about your situation with someone, it kind of just by it, you can start kind of saying, well, I think I should try and do this and I should try and do that. And and then you can actually start putting together an actionable plan, about how to improve your life. Whereas if you don't talk to anyone about it, it just remains as thoughts in your head. You might just kind of not get round to ever doing it. You might, because of your situation, you might just think, oh, everything's hopeless, and you might just kind of stay stuck in that rut, actually. So
absolutely. I mean, and that's why therapy is can be so helpful and healing, really, because if all that stuff's trapped in your head and it's bouncing around your head, you can feel overwhelmed by it and you can't identify. But talking about it, finding your own answers can initiate and encourage motivation within you to make changes to your physical environment or your daily life, engaging in exercise, communicating with people. All of these things can alleviate distress and promote well-being.
I mean, John, do you think anxiety and depression, whether it's a diagnosis, a disorder, or whether it's just the emotional state of anxiety and depression, do you think those things actually are increasing, or people are just talking about it more?
I think people are talking about it more, and that's great.
You don't think it's any worse than it was 20 years ago, then, rates of anxiety or depression, or 40 years ago?
I think anxiety and depression have always been there, but I think that people were perhaps more, there weren't any available options. It wasn't culturally encouraged to talk about your feelings and so on.
Because a lot of people.
As I said, talking about your feelings is great and helpful. And what's most desirable is that by talking about your feelings, you can move forward in life and learn to manage your regulate your feelings and thoughts in a more healthy way, which in the long term is a far more beneficial outcome than being on long-term medication.
Do you think? No, I think you're right. Do you think there's a danger? Actually, with all the people talking about mental health, you hear some people sort of bemoaning the sort of I don't know. I think they describe it as emotional incontinence, and they give Meghan Markle as an example. You know, this kind of gushing, talking about, you know, their sort of distress, and this has almost become like a thing that a lot of celebrities have started doing, especially younger.
Oh yes, I mean, definitely.
And then they kind of say that this is a bit over the top, this emotional incontinence, and then they kind of bemoan the sort of the move away from the more stoical attitude, like almost like the British stiff upper lip of not kind of expressing your emotions, and then they say that's much better. But I mean, I sort of think those are two extremes of the spectrum. I think there's probably a happy medium, because I'm not a huge fan of the traditional British stiff upper lip and never talking about. I think that's actually a form of emotional repression, and I don't really favour that. And I always remember when I was a student, I met this Italian girl we were at this restaurant for lunch. You know, it was a big group of us, and the Italian girl there, she kind of said, the British are the most emotionally repressed people I've ever met in my whole life. And she was just adamant about it, that, you know, there's something that British people were just horribly emotionally repressed. And I kind of thought to myself, you know, she's probably got a point. So you got, you know, so I think the stiff upper, I think stoicism, you can take it too far. I can see some benefit to the stoical attitude, but I'm not massively into that. I think there's a happy medium between stoicism, stiff upper lip, and emotional incontinence on the other end of the.
Yeah. I mean, I think, you know, with any cultural trend, you know, people, some celebrities will, and some people will kind of appropriate that trend. You know, okay, you know, I've got PTSD. You know, and they may do so with good intentions, or on the other hand, they may do so because it's a popular social trend that they're exploiting. But then that's human nature to some extent, I think.
But I think in some groups, I think anxiety really is going up in certain sections of the population. And I would sort of give the example being sort of teenage girls in both the US and the UK, probably anywhere in the West. And there's pretty strong evidence for that. I don't know if you know a book by a psychologist called Jonathan Haidt. He wrote a very well-known book called The Coddling of the American Mind. Have you heard of that?
I think I've heard of it. I've never read it, though.
Basically, this book, Coddling of the American Mind, he's talking about how sort of young people in the US today have basically, during their childhood, they were sort of incredibly overprotected compared to young people sort of 2 or 3 decades ago. So people in their 20s and early 30s now, they just had this massively overprotected upbringing, and so it didn't enable them to sort of develop the sort of resilience that people who, you know, say people who are in their 40s and above, when their upbringing, they were allowed to go much more just out and about exploring, you know, a long way from their home, you know, getting up to all sorts of mischief and just taking sort of risks, and that enabled them to develop the resilience. And also the other thing is the social media, especially the whole social media thing is having a massively negative impact on teenage girls' mental health, because they're just looking at Facebook and what's the other one, sort of Instagram, that's it, Instagram, and they're seeing all their friends, you know, like, and they're thinking, oh no, I'm not as good looking as that friend, and, you know, it's making them paranoid basically. And they've got hard evidence. It's not just girls self-reporting as having anxiety. Actually, the number of teenage girls in the US is probably the same in the UK as well, who are actually self-harming has gone up massively in the last decade, and also the suicide rate amongst teenage girls has gone up quite a bit.
Yeah.
So
yeah.
So
and in young boys as well.
Oh, really? Yeah.
Eating disorders.
Yeah. So I think that
the thing that occurs to me though, you know, and while I'm, you know, no way would I be advocating the stiff upper lip approach, because you know that's the antithesis of my belief that expressing your feelings and thoughts is in itself beneficial. But I mean, what you describe is true. I mean, we're all of our time. I'm quite considerably older than you. So
only a few years, John.
It feels believe me, it feels considerably more.
I still have a very youthful air about you. It's,
thank you. But you know, the kind of identification of trauma,
right? Yeah.
What in some cases, and this might sound a bit judgmental and rather harsh, but I kind of feel sometimes people identify trauma as, to me, what's part of the developmental process to a certain extent. Obviously, I'm not talking about physical, sexual abuse or emotional abuse, but part of the developmental process for a child and a young person is to meet challenges, to work through those challenges, and move through the process of development. And sometimes those challenges can be tough. You know, I think you're absolutely right about this coddling thing and this lack of resilience, because that's very much has been a buzzword for quite a few years now, because that's what people seem to be, particularly young people, but not just young people, people of all ages seem to be lacking. And you know, the focus now is on ACE, you know, adverse childhood experience. You know, as being a cause of conditions later in life. But you know, I think we need to sort of add a caveat to that actually some form of adverse childhood experience can actually be beneficial, because it enables the child to move through the process of growth and development. So again, it's a matter of degree, I suppose, really, Nigel, isn't it? As you say, there's black and, you know, there's these opposing sort of conditions or diagnoses, and that's really my approach is sort of recognizing, rather than falling. I'm not a medical professional, so, but I think my view of human beings is basically that we're all on this spectrum at some point. You know, we can display or exhibit symptoms of different pathologies, if you like. I just find that it can be a bit reductive to reduce a human being to, you know,
well, especially when people define, like you said, when it becomes an identity. So I mean, I was watching a YouTube video like recently. This woman was saying my autism, and I was thinking, you know, there's no way she had autism. I mean, I've looked into actually the diagnostic criteria for autism spectrum disorder, and they're actually quite hard to meet. Like, so I've kind of changed my view now. I think if someone gets a diagnosis for autism spectrum disorder, then it's actually, you know, if they get the diagnosis properly by a psychiatrist that's evaluated them properly, then I think they definitely, you know, do have some challenges, like, you know, So, but I don't know, but there is a tendency for people with that diagnosis to then define themselves by it. So, I mean, I was reading an interview with this guy who works for the BBC who got a diagnosis of autism spectrum disorder, and he kind of said it sort of completely changed the way he thinks about himself, and now he knows that, like, when before he just always wondered why he never felt like he fitted in, now he knows why that is. And but now he kind of but it's become like his identity. He said it's kind of given him a whole new lease of life, and he kind of gives talks at conferences and writes articles all about autism spectrum disorder. And another person was saying, oh yeah, my friend was she told me when she found out about my ASD diagnosis, how proud she was to have a neurodiverse friend. You know, it's like, just, I mean, but actually,
it becomes appropriated, and it becomes a badge almost.
Yeah, this guy said, diagnosis has unlocked a totally different version of me, he says. From struggling to make friends, he now has hundreds of friends. He is able to be upfront about it. Yeah, speaking at events, organizing festivals dedicated to specialist learning, writing, training, and teaching about autism is now his focus. But actually, that's kind of a positive thing in a way, isn't it? Because it's given him like an identity. But yeah, that's it. Barney now can talk about what makes him who he is. But that's the thing I find a little bit problematic, that last sentence there. He can now talk about what makes him who he is, because I think it's great that he's kind of, it's given him this new lease of life, like something to kind of feel passionate about and speak at conferences. But it's the idea that autism spectrum disorder diagnosis makes him who he is. Like it's just part of him. It's not the defining thing. To me, that if he's got an ASD diagnosis, he shouldn't think of that as being the thing that defines him. It's just part of him, perhaps, right?
Yeah.
You see what I'm trying to say here, John?
Well, I agree with you 100% about that.
Yeah.
You know, I think but in that case, good luck to that guy. It's improved the quality of his life, and my view is that if something works, that's great. It would be worrying if that person was unable to access parts of their individuality, or aspects of themselves, or potential, due to the constrictive conceptual framework of diagnosis.
Well, yeah, because it could have gone the other way. I mean, I think sometimes a diagnosis of a type of neurodiversity, such as ASD, or maybe a psychiatric condition such as depression, it could almost go the other way. Like the person might think, well, can't do that because I have clinical depression, or I can't do that because like I'm on the autism spectrum. So because I'm on the autism spectrum, then I'm really uncomfortable around other people, so I can't go to that event, or can't really go to that party. It could almost be, so there could be, I don't know, so it could go the other way, couldn't it, actually?
It could, and it does, I think.
And also it could have like negative impacts. Yeah, because sometimes a diagnosis of something, I mean, could have a negative impact, maybe on someone, getting medical insurance or something like that, or even getting a job. Because sometimes when you go for a job, the employer might, sort of insist that they can see, or you declare if you have any diagnosis for any psychiatric conditions. And it's sometimes stipulated when you apply for a job that if the company requests to see your medical record, that you'll allow your medical. Yeah, so, let's say you got a diagnosis of autism spectrum disorder, or I don't know, general anxiety disorder. You probably, when you apply for a job, you're probably not going to want to admit that on your job application.
That could potentially result in a form of discrimination. And
in reality, most companies, they might probably not going to want to employ someone if they see on the application form that they got generalized anxiety disorder, right? So if you've got that diagnosis and you don't want to admit to it, like, and they want to see your medical record, you probably won't get the job. So,
I mean, just as a kind of side effect of what you're saying, you know, there are probably some companies would jump at the chance to employ somebody who was perhaps autistic, or because and people with ADHD can have immense levels of creativity. You know, so there are, you know, as you well know, there are many quite famous people who have these diagnoses, who have been incredibly creative and high achieving.
Yeah. Actually, I lost the sound. I couldn't quite hear what.
Oh, sorry.
I don't.
I'm saying that.
I think your microphone kind of goes quiet every now and then. It's not. Don't worry about it. I think it's fine, John.
Okay.
No, what were you saying just at the end there?
Saying that you know, some of these conditions can also incorporate a great deal of creativity and, you know, high performance in, you know, in certain areas, both sciences and arts.
Yeah, you're right. On the topic of ADHD, I might have to wrap this up in a minute because I've gone well over. This is really well.
I think, Nigel, I think we're both displaying symptoms of ADHD.
Just I need to check my phone. I've had a whole load of messages come through in the last few minutes. No, it's just well, actually, we're going to have to wrap up because we've both got things we need to be getting on with. But just as a last headline thing, I actually discovered that, again, from the CDC, Center for Disease Control information, I discovered that in the US, 20% of school-aged boys have got an ADHD diagnosis. 1 in 5. I mean, that's insane. And of those 20%, half of them are on Ritalin or
Ritalin,
So basically, they're giving stimulant medications to 1 in 10 school-aged boys in the US. I mean, like, that's, to me, that is just insane. I mean, there's something definitely wrong there. Like the idea that 1 in 5, like teenage boy, you know, young boys in the US has got ADHD. I mean, to me, I don't buy that. That is definitely overdiagnosis. Like
how, and this raises the question of, you know, which I was kind of hinting at before about the social control aspect.
Oh, I see. Yeah, right.
So you've got a child who's perhaps a bit disruptive in the classroom. You know, it can then become a kind of, you know, I'm taking a more kind of, what's the word? Kind of that sort of Foucault-like approach to it.
Oh, Michel Foucault. Oh,
yeah, you know, kind of like looking at the, as what we're talking about, what you've just mentioned, as a manifestation of the way power is balanced and funk is articulated.
What was Foucault's famous book on the sort of the mental health, psychiatric industry?
Well, he's got several.
The history of mental.
The history of madness.
Oh yeah, the history of madness. That's it. Yeah. So you think psychiatry as a profession might be, you know, to some extent, has a kind of social control aspect of it, doesn't it?
But I think there is that. I mean, you've only got to look at the Soviet thing, you know, in the past. You know, I mean, basically, you're right. If you don't conform, you're either mad or bad. You know, and I suppose the part of me, you know, I suppose part of the way my way of thinking is related, because we're all subjective, and the way I think will always be partly a result of my history. You know, but I found that I could relate to a lot of the so-called anti-psychiatry approach in the 60s. I mean, Foucault he denied that he was allied, or he was, you know, a part of that. But you know, there is definitely a structure of power. I mean, you know, the psychiatrist, there's an old joke. What's the difference between God and a psychiatrist?
Don't know.
God doesn't think he's a psychiatrist. I think I've said that. You know, meaning the psychiatrist thinks he's God.
Oh, okay, yeah.
By the way, if you hadn't noticed, I'm absolutely terrible at telling jokes.
I wasn't sure when the punchline was.
I'm actually wondering if I've got it the wrong way around, but anyway, that's a joke in itself.
Anyway, so it's actually quite a good one, actually. Where was I? We're going to have to wrap this up, actually, because it's been I did have one other point I was going to make, but it's slipped my mind now. But we do have to. What was it?
Okay.
Anyway, yeah, but it's been great. I've really enjoyed this. I think we'll have to have a part 2 to this discussion because
I think we should.
Because actually need to talk a bit more about the whole neurodiversity angle and the whole issue of because when you think about it, maybe sort of teenage boys are being over controlled. I mean, if they're so hyperactive, I mean, I personally think it's because they're not getting enough exercise and they spend too much time staring at their smartphones.
That's a very good point.
Teenage boys need to be out and about, running around, getting up to a bit of mischief, you know, and they're not burning off. And it could be like we're trying to control, or maybe we're feminizing teenage boys too much, trying to force them into, you know, just sitting quietly and all this. So it is a way of giving them Ritalin. It's like a way of, we're trying to control them in a way, isn't it?
There is definitely a control aspect to it.
Yeah.
But that's something perhaps we'll
have to talk about that. Okay, next one. All right, well, thank you very much, John. It's been an absolute pleasure and delight, as always. And
likewise, thank you, Nigel. Really enjoyable and lovely to see you.
Take care. Cheers, then. Okay, bye.